Right. Okay, sorry. So our chair for this evening is Dr. Saleyha Ahsan, and she's an emergency doctor currently working in ITU in North Wales. And she's currently also working on a PhD in Cambridge on the impact of health, on the impact of attacks against healthcare in conflict zones. She's also a filmmaker and a broadcaster and a former captain in the Royal Army Medical Corps. Some of you might recognize her from the BBC Two hit series, Trust Me, I'm a Doctor. And our first speaker is Dr. Daniel Grace, a portfolio GP, event doctor, and an expedition medic based in South Wales. He's also a medical director for the Virtual Doctors Charity, which offers remote medical advice to healthcare workers and doctors in rural Zambia and Malawi. Not only that, he's also the co-founder for the Wilderness Medic and hosts the Wilderness Medic podcast, which is available on all major platforms. He will then be followed by Captain Scott Pallett, a microbiology and infectious diseases trainee doctor with special interest in expedition medicine. He has experience as a team leader on remote expeditions in sub-Saharan Africa and the jungles of South America and Southeast Asia. More recently, Scott has led the Rangers' first Africa program on behalf of the anti-poaching organization Wild Cross. So I would like to now pass on the microphone to our chair, Dr. Saleyha. And I'll just unmute Dr. Saleyha.
Hello, good evening. First of all, I want to say a big thank you for having me and for asking me to chair this event. It's a brilliant event, and I wish that something like this had been around when I was a medical student. I've just been finding out more about the organisations over the last week or so. It's really exciting. The mission points are exceptional, particularly the mission statement for seeking justice and equality for all when it comes to health and access to healthcare, which is a subject very close to my own heart, and many people within global health. So I'm really excited about the development of organisations like this and healthcare professionals for global health. It all needs to start early, and the fact that there is students for global health working in collaboration with health professionals for global health gives me a lot of hope for the future. Now, I'm going to confess it's my fault that we are running slightly late, and here's the reason why. Yes, I do make films, and today, the day is a day when both of my careers have collided somewhat. So I'm actually filming in my own hospital in Ysbyty Gwynedd, and we were following a patient story. It's all related to COVID. And we had this exceptional case of a man who's come in for day surgery for a knee replacement. Knee replacements traditionally not normally done in a day, but because of the pressures of COVID and the huge impact that has had on elective cases being held up so hugely, we're being pushed into, we're evolving into new ways. And there was this exceptional case today that I just had to film, and I had to film him leaving the hospital, safely delivered into the arms of his wife and waved goodbye. We first met him at 7 this morning. So that's why I'm late. I'm so sorry, but I am not going to talk about me. I'm going to move on to the two really exciting speakers that we've got this evening. They've already been introduced by Zoom, so I'm not going to go through all of that. So without further ado, I'm going to ask to come to the floor Dr. Daniel Grace, a GP and an expedition medic, to come forward with his talk. Thank you, Daniel.
Yeah, thanks very much, Saleyha, and thanks, Zin, for the introduction. I'm just going to hopefully share my screen. Hang on.
There you go.
Slideshow button. Where's it got? Sorry, I just got that bar in the way. There we go. Got there eventually. Right. Hopefully everyone can see that. So yes, my name is Daniel. I am a GP and I'm based near to Brecon. I moved here about 2 months ago, which is excellent. Really nice part of the world. So today I'm just going to give you sort of a whistle-stop tour of how I developed a career in expedition medicine. There's lots of different ways you can go about doing it. And then I'm going to also touch on a few trips that I've done and just tell you a bit about some of the things that have happened. So first off, just a little bit about me. So I trained at your rivals, the rivals to Imperial, GKT, which was very good. And then I went off, did the foundation program and GP training in the southeast of the UK. For me, it was always worth continuing to get my CCT, so to complete my training, rather than taking time out after my foundation program, because I wasn't sure if I'd ever come back to anything, and I didn't want to have a training pathway sort of lingering over me, if you like. And then since then, I've sort of had a portfolio career, picking up little bits and pieces, really. So as Zin was mentioning, I'm involved with the Virtual Doctors, which is a charity that gives telemedical advice to rural health centres in Zambia and Malawi. I won't tell you too much about that because I could talk for hours on that. Do a bit of, well, not so much at the moment, but I've done some event and expedition work, which is obviously what I'll tell you a bit about. And then the other stuff I'm doing at the moment is working with 111, working back with GKT, doing some medical student teaching remotely, and then writing some expedition medicine scenarios and things for the Uni of South Wales, and also doing some work with World Extreme Medicine. So lots of interesting things. These are just some pictures just to illustrate what I've been up to. So yes, this was on a simulation course. I'm dressed up as the nurse, and then doing some teaching at the top, and talking to a BBC South East reporter about the Virtual Doctors when we were trying to raise funds to help with our COVID response. And I guess that moves on to the elephant in the room. So obviously, you can't go to a webinar or a talk without COVID being mentioned. It's a slightly strange topic to talk about: expedition, wilderness medicine, travel, all these things at the moment, for obvious reasons. But I think that if there is a silver lining, it's the fact that actually more people are able to kind of join these talks remotely, which I think is really nice. Normally it would be in whichever uni, say it was at Imperial or wherever, whereas everyone can sign in from all over the place. I think that's a really nice thing. And even this is a nice example, the vaccine, everything like this. Everyone seems to be more interested in sharing knowledge and sort of appreciating the global aspects of health. And I think that fits in nicely with the themes of both students for global health and health professionals for global health. So yes, expedition medicine. So I actually came to the field of expedition medicine quite late on. So at the end of my GP training, there wasn't any sort of student societies that focused on wilderness medicine, expedition medicine when I was at medical school, which is a shame. So the way I did it was, instead of doing the GP examination courses, I saved my study budget and went on an expedition medicine course in Plasibrennan, and it was great actually. I finally got to meet people who sort of thought the same way that I did, and it was really eye-opening that there was a similarly like-minded collection of people all in one place, and they weren't just tunnel visioned, focused on either becoming a cardiologist or a surgeon or whichever, and that was really nice. And the thing about that course was it went on for about 5 days. It was a whirlwind tour from sort of altitude, heat, cold, and it was fascinating, but it also showed me that there were so many different topics that I had no idea about. And so to sort of look into that a bit more, I enrolled in this diploma up in Glasgow, which was really good fun actually. You can see in some of these pictures that isn't the jungle like Scott's going to be talking about. That's actually just a forest in Devon. But we also went and found out about the DDRC, which is the Dive Medicine Centre in Plymouth. Did some stuff out in the snow. Obviously, we were in Scotland, so it was obligatory to go to a distillery. And then the bottom picture is actually us extracting the course director from a jeep in the desert in Morocco. So it was really, really interesting. And the reason that I thought a diploma was a good idea was partly to fill those knowledge gaps, but also just from a medical legal point of view, I wanted to have someone externally validate me as a GP, so that if, hypothetically speaking, something went wrong when I was on an expedition, they didn't say, well, look, you're a GP, this isn't a GP surgery, what are you up to in the middle of nowhere doing this? And then as I learned more, I realized still I didn't know that much. So we had sort of a day on tropical medicine, and that really whet my appetite. So to follow this up, I went up to Liverpool. That was actually at the start of this year. That was very interesting, partly for expedition work, but also for the work that I do with the Virtual Doctors Charity, so that I can help give advice and shape the service. Sadly, obviously, as COVID was developing, the lecturers sort of had to go off to help with either WHO or for the infectious disease wards. So that obviously the rest is sort of history, as they say. But yeah, moving on to how to sort of get involved. So the first thing to do is actually to think, how do I get experience outside of the hospital or outside of the GP surgery? And you can do this as a medical student, as a junior doctor, or even sort of like I was doing as a GP. And starting in the UK is a good way of sort of getting a flavour of what it's like doing medicine in the middle of the field. And so lots of, obviously back prior to COVID, there were lots of events going on. Obviously mass participation makes that a bit difficult at the moment. But things like ultra marathons, long distance cycling events, they're all very good. And the nice thing about it is you tend to have a nice team behind you, so that you can sort of bounce ideas and just get used to not having the kit that you'd have in your research department or other places. I think the one thing I learned at the start was that it's important to just hassle people to try and get these opportunities and network, and then email them again, and don't take no for an answer, because there's a lot of people who will be trying to get experience, and if you persevere, you will tend to get it. And the main reason, apart from obviously the UK being a bit closer than some places, is that a lot of companies like to see how you work within a team, how you sort of interact, whether you're a decent person, basically, before you might get the opportunities to go overseas. You typically see quite minor conditions, blisters, aches, pains, that kind of thing. But we had a case of someone collapsing with SVT. We've had some ACS, asthma, and a traumatic hemothorax on this cycle ride after someone fell off their bike. So it keeps you on your toes. But I'm just going to tell you about two specific trips now. And I guess the themes with these are to expect the unexpected. So this was back in 2018. I went out to Kenya, and we were looking after a group of, I think it was around 80 participants who were going to be running a marathon in this beautiful location here. And you can see it's a lovely day. These are the tea plantations of Kericho. They're at about 2,000 meters, and it's where lots of the elite Kenyan runners go to train. And so it's obviously a great place to do a marathon. Lots of the participants were from the UK and Europe, but some local Kenyan athletes also joined in. And a lot of them were raising money for a charity called Five Talents. And what they did was, essentially it was like a micro loan setup. So like they would give loans out to small businesses and try and make them self-sufficient and support community projects. So the really nice thing about that was that the participants got to see some of these projects, and we assessed the hospital, which is an important part of your sort of preparatory work if you are on a trip like this. And the hospital was quite good. It was suitable to manage simple fractures, get some bloods and stabilise patients, but anything more serious would need to go sort of evacuated to Nairobi. And there was a landing strip for flying doctors if needed. And I suppose if we're thinking about this in a global health context, and this is for all expeditions overseas in general, if you're going to a resource poor setting, is there's a bit of an ethical conflict. So you're sort of going to somewhere, you're potentially using up their medical resources and also other resources, you know, food, your impact on the local ecosystem and things like that. But then at the same time, you could argue that having events like this is helping support the economy. And it's an interesting thing to think about. I'm not saying that there's a right or a wrong answer to that, but it's worth thinking about. So yeah, it was an interesting trip. So I didn't envisage Kenya to be like this. It started off with a beautiful day, like it was in that last picture. I was based in this little hut here with a colleague, and we were just enjoying the weather, patching up a few blisters, and then within about 5 minutes, it became a total whiteout, torrential rain, hailstones, and all the runners obviously were not prepared for this. They were wearing shorts, very thin running gear. No one had any waterproof layers, and in our medical kit, we didn't really have the things to deal with hypothermia because we hadn't really thought that was going to happen. I think I had in my own rucksack, in my medical kit, one foil blanket. We luckily had a flask of tea, so we let some of the participants have that. You can see in this picture here, they are sort of all huddled under this tarpaulin, which was more to kind of keep the sun off. And I think that's the moral to this story, was that, you know, make sure you adequately think about, you know, where you are. So unlike being in the Masai Mara or somewhere it might be hot, you're slightly more altitude. It's quite a potentially wet place. It happened to be the sort of the worst rainstorm or hailstorm in 25 years. And then, you know, the risk of hypothermia meant we had to cancel the race. So that was an interesting learning point for me. The good thing about it was that we did manage to get to see some wildlife, not in the tea plantations, luckily. This was in the Masai Mara. And I now just want to show you a story about a trip in Canada, so quite different, but with a similar sort of theme. So this was a year later, so last summer, and this was traveling to the Yukon, which is in the north of Canada. And it was with a company called British Exploring, and they are a youth development charity based in London, and they essentially try and give young people between the ages of 16 and 25 sort of an experience that they wouldn't necessarily get. So some people can self-fund and go on it, but the majority of people that go on their expeditions tend to be through a schools referrals program, so people who would sort of benefit most from these things. And the nice thing about it is that it is sort of taking them out of the UK, taking them somewhere where they can sort of forget about any potential problems that they're having back home and have a blank slate and sort of learn and develop. So I'm just going to show you where the Yukon is. So it's up here next to Alaska. And this story actually is all to do with what happened before we were joined by these young people. So hang on, my dog's at the door. I've just got to go and let him in. Come on, stop scratching. Go in your bed. Sorry. So so this is the story of what happened before the young people came out. So we went there, myself and 3 other people, to sort of make sure that everything was set up, because they had kit out there from a few years ago. We had to make sure the tents were all in one piece, and sort out various other bits. And we had been there for a few days. This was our transport, this pickup truck, which was great fun to drive. And we checked out our base camp. Everything was all shaping up quite nicely, actually. And we went back to Whitehorse, which was the capital city of that part of Canada and that territory, which was a good 8-hour drive away. And unfortunately, when we got there, or the next day, we found out that a forest fire had started about 15 kilometres from where we were. And this progressed, and you can see this is an aerial map of the local this is the small village nearby, basically. It's certainly not a city, but it's called that from back when the gold rush and things were all based there. But the main issue we had was that it was doubling in size, and that they'd decided that they'd issue an evacuation alert for the areas around the roads that would get to where we needed to go. And the main issues here were that we were expecting sort of 60 young people to turn up, and then there's the risk of a fire coming to our camp. And you can see here it had grown substantially, and I was quite concerned from the point of view of, we had some people with stable asthma, but smoke inhalation is not a good thing. And myself as a GP, I don't have the skills to intubate someone. We don't have the equipment either. If someone does develop acute respiratory distress or airway burns or anything like that. And this picture makes it all look very dramatic. And this is not my photo. It's a photo from one of the Canadian news websites. But on the ground, it looks lovely. And the expedition leader was like, "Well, it looks fine. Let's just go there. Look, there's a sign that says active forest fire, but it doesn't look like that." And it was an interesting situation because obviously checking and risk assessing for forest fires is not something that you necessarily do day to day back in the UK. And it's quite difficult. You're managing the expectations of sort of a leadership team, but also that you've got all these people who are looking forward to having a great trip, and they're sort of coming the next day. So I'll just show you some of the process that we went through. So first off, we came upon this really useful resource actually that gave us smoke forecasts. And you can see that basically the darker it is, the more smoke there is. Unfortunately, our camp was here where the heaviest smoke particles were going to be forecast to. But we were sort of like, well, what does it actually mean for people? It obviously doesn't look that good, does it? But what does it mean? So we found some useful guidelines, which essentially said if they're above 101, which was quite a bit lower than these were forecast, basically not to be outside and try and reschedule your exercise or what you're doing. And then we were meant to be hiking in the wilderness, so that didn't quite fit. So next we looked for some other guidelines to sort of help us make our assessment. We came upon some from California. And again, their advice was, well, stay indoors, but we'd be in the tent, close windows, and avoid activities again. So not particularly useful. And there weren't any sort of wilderness type guidelines apart from sort of avoid the fires and try not to start them in the first place. So what we did after a lot of discussion was, we knew the flight was coming in with these young people, and so we decided to head back to the base camp and see what was going on. We met some firemen who were actually very helpful, and they'd been quelling the fire. They'd got a whole bunch of helicopters in. They'd been setting up fire breaks, sort of working throughout the night, and there was also some unseasonably heavy rainfall, which was quite lucky. So we sort of had a chat with them, looked at some of the satellite photos. These are some of the helicopters. They had 7 of them just to control the fire, and you can see there's a big puddle there. So luckily the weather was on our side, and this was at our sort of base camp where we were setting up our tents to sort of hike out in various different directions from here. And they even sort of flew their helicopter. So we were just about to head off, say it's probably fine to go. And then the helicopter landed in our field, which was nice. But they gave us a bit of a reassurance, I think. And you can see just on this other picture, it's kind of smouldering, having had some heavy rain before that. But I suppose my learning point here was that this, again, was something that wasn't something we'd particularly thought about. we'd sort of thought about what to do when out hiking in terms of lighting fires, controlling fires, not starting a fire, but what to do when, when there's a fire that's threatening your whole expedition before it was going to start was quite interesting. And for me, I think the main thing that I learned on both of these trips was it's not always the medicine. And there's a lot of focus on all the different exciting medical things that can happen. And that's obviously important because lots of, you can have medical issues, but a lot of the time it's the logistical, non-medical issues that can sometimes throw a spanner in the works. They're interesting to find out about and also to sort of experience and look back on. And I think you also learn quite a lot in terms of how you are as a person in these sort of stressful situations and trying to plan and negotiate things.
Dan, sorry, it's just me, it's Saleyha. I think we're going to have to wrap up soon because I've got to let
No
Scott.
worries, I'm just about to go on my last slide.
Right, thank you.
That's okay. So, yeah, that's just a whistle-stop tour. So my take-home messages are essentially to, get involved with the things that expose you to global health, travel health, expeditions. And by being here, you're doing that, which is great. Make sure you network, and that is really important. And have a think about attending an expedition medicine course as well. So do I have time to show a quick video, or shall I leave that till the questions bit?
I think we might have to, sadly today.
That's okay.
But sorry about that.
Any questions, then maybe if there's time, I'll show my video later as well. I'll pass you back to Saleyha there.
Thank you so much for that, Daniel. I'm so sorry to have. I'd love to.
No, that's fine.
But we might have time at the end. But I know that we want to also leave time for lots of questions for everyone. So,
of course.
Without any further ado, I am going to introduce Captain Scott Pallett. I'm really pleased to say a fellow RAMC colleague. I left the RMC many years ago, but I think once a member, always a member. So really, really pleased to introduce Scott, who's a microbiology and infectious diseases trainee, but also within the RAMC as well. Scott, over to you.
Fantastic, so thank you very much. Right, I'm going to just make sure that my slides actually share. So 1 second. This one. And just for someone to confirm that you can see that.
Yes, we can see it.
Cool, brilliant. Okay, so thank you very much for having me, because it is always fun and exciting to get to talk about disappearing off and doing things all over the world. And never more so, I think, than over the last sort of 8 to 9 months, where everyone is probably feeling not only a little bit fatigued, but also all of these sort of things are certainly sitting on the back burner. I'm going to take a leaf out of what's just sort of happened in the last 10 minutes, and actually I could talk for quite happily for hours on a number of different topics. So I'm going to try and whistle-stop tour and just hit some highlights and leave you with a couple of just sort of food for thought moments before you think about sort of signing up and sort of disappearing off on a variety of things that are available, and then perhaps sort of signpost a couple of organizations that I've had a lot of luck through in order to get that sort of experience that Daniel was talking about. So the first photograph here, I've got a particular love of the jungle. Jungle is where I'm happy, and savannah, sort of fringe, is possibly where I might be content, but jungle is sort of my favorite place to be. And jungle's probably, well, the Antarctic, the most difficult place to sort of set off to. And the sort of picture here is very, very picturesque. So this is actually wandering down the Zambezi when we were doing some anti-poaching work, and it looks rather lovely. But as we sort of go through, I'll just try and show you the other side as well. So this is one of the people that perhaps made me sort of really excited about the idea of doing expedition medicine. And while he has his flaws, certainly, so the gladdest moments in human life, methinks, is the departure upon a distant journey to unknown lands. And I think if that doesn't sort of spark in you an excitement about wanting to go off and disappear and do something, then you're probably in the wrong place. So hopefully everyone sort of can gel with it. And that's Sir Richard Francis Burton, so very famous during the early days of the exploration of the inner Africa and the search for the source of the Nile. And just sort of hold that sort of quote as we go through. And I've got another one that's sort of perhaps slightly more tempered at the end. And I think what you need to be is somewhere, as the medic on any expedition, you need to be somewhere between this and the last quote that I have. So just try and remember that as we go through. Lots of these photos are from just different times where I've been away. Actually, the photo on the right is my wife, and the photo on the left is one of the anti-poaching rangers in just south of the border with the Democratic Republic of Congo. And I think what I wanted to do was just develop something that Daniel was saying just a moment ago, and just really do think about where you're going and why you're going, because sort of when you're working in the NHS and you get that sort of sense of, you know why you're going to work, and you always have sort of a mandate to be sort of doing the work you're doing and the help you're offering. And I think you just got to be very, very, very careful not to get sucked into something, particularly in what is now very much an eco-tourist world, and just make sure that what you're doing is ethical and it is sort of like a moral project, and you're not sort of adversely affecting where you're going. And just think about what the needs of the place actually really are, and that the first sort of order of business isn't that you're trying to increase your experience, but if you're going out there in order to be helpful, is that you're actually leaving a legacy behind that is helpful. And the reason the photo is here, certainly on the left, for this anti-poaching gentleman, is it's all well and good sort of like going out on expeditions and delivering kit and things like that, but what you should be aiming to do is sort of impart a little bit of the knowledge that you have, and they're going to be able to impart a little bit of the knowledge that they have to you, and so that you can leave them sort of a little bit better place to be able to tackle the difficulties that they have. And certainly at the moment in Central Africa and East Africa, anti-poaching is ramping up, and I think even COVID has probably made it worse rather than better, because ecotourism has died and people are a little bit more desperate. And obviously animal wounds and sort of RTAs are the biggest problem, but also poachers and gunshot wounds and snares. And when you are sort of 400 kilometers from the nearest hospital, but also 10 hours on foot from the nearest road, things become very difficult very quickly. And it's just about sort of thinking early about the sort of things that you can help with. And often that's something very, very simple. And just whether you're the medic or not, I think the role that you end up sort of forming, and this is very, very similar in the army actually, is that you will end up being asked to advise on certain things just because one assumes that you have a certain level of common sense. So these are sort of like the four things you really want to always think about. Okay, so just very, very quickly, the route, so this on the left was very much the only road in and out, and about 5 minutes before that photo was taken was a dry road that is now a flooding river, and things can change very, very quickly. Your comms plan, if it's not at least 3-tiered, then you probably shouldn't be going where you're going. And I can't describe the number of times where I've gone somewhere that has had satellite phones plus shortwave plus longwave radios, and the only thing that works is the cheap mobile phone that you bought from the airport when you arrive sort of in Nairobi. So always try and have a 3 or 4 tier comms plan, because everything always goes wrong. And birds have decided to nest in our comms tower here. Your evacuation is absolutely paramount, and as the medic on any expedition, it is absolutely one of your first tasks to decide how on earth, if you were to go somewhere, could you get someone back out. And there are some rather structured models to think about sort of your time frames to be able to get people in and out that I'm not going to talk about, but just some places are very easy and you can get fixed wing, and when you've got fixed wing you can bring anaesthetists and you can bring ventilators, but quite often when you go to the jungle there's nowhere that you can land. And actually what you're likely to get help with, if they can come, when they can come, because often daylight hours is the only time people will fly, even when they can come to you, is perhaps perhaps a doctor, but quite often a paramedic. And it's just sort of making sure that you are satisfied that you've got that sort of plan in place. And the last one's the environment. And this picture is a fun little chap that we're at the moment trying to get a name for with the Natural History Museum, who bit one of my guys when we were in South Sudan, and caused a rather fun reaction, which I'm not going to try and go into now. But basically, nothing will try to overtly kill you often if you don't bother it. But often, the environment does absolutely nothing to try and help you either, and it's just sort of about having awareness, because sort of a traditional medicine teaching program leaves certain things obviously off the program, because while we see chest pain and cough and breathlessness on a daily basis, I don't think centipede envenomation and snake bite and things, heat injury and cold injury are sort of what we're seeing come through the door at ED. So it's just about sort of making sure that you've got a little bit of awareness at least of those kind of things. And then the animals. So these all are photos, and it's just sort of, whilst everything looks hunky and dory and you're off on safari, when you're actually on expedition, things become a little bit different, and actually staying very, very clear is often the first and best thing that you can do. So I've never had a run-in, none of these ever developed into anything bad. I've never had a run-in with any cats. I have had an elephant that decided to stick a tusk through a wayward photographer's leg, who decided he would wander off and get himself between mummy and baby. Again, just think about where you're going and what your expertise is and why you're there. And whilst you're meant to be risk assessing everybody else, just sort of make sure that your knowledge and your behavior also isn't putting yourself at risk, because you get injured and then no one has a medic and the whole thing kind of falls apart. And then most of my thing is photographs, because photographs are better. So this is a photograph of the jungle canopy of Southeast Asia. And it's just literally to highlight to you the complications of being able to evacuate anybody from anywhere. So when things do go wrong, quite often you've got to spend most of the day cutting a hole into the jungle canopy in order to be able to just get a basket down to get someone out. So sort of forward planning is absolutely everything. And part of that job, you know, at the moment, if you're sort of thinking about your job in the hospital or your potential job in the future in the hospital, suddenly you become travel medicine doctor, you become occupational health doctor, you become emergency doctor, you become GP, quite often you become counsellor. And while we're on that note, sort of when you're picking your junior doctor jobs, if you've still got those in front of you and you want to do expedition medicine, then psychiatry is a fantastic rotation to get, because you'll find that people don't really understand the stress that may be placed on them by expeditions until they go and do them. And it's a very good job to have done. There we go. So I'm just going to spend the rest of my time talking about snakebite, because it's really, really important. And the WHO raised it up, back up to the sort of high priority list for neglected tropical diseases, beginning of the year before, end of the year before last. And it is a big problem, especially in the places that we like to go, which is South America, Southeast Asia, and Africa. And I want to introduce you to my favorite snake, which is a fun little chap with some fantastic evolutionary adaptations that doesn't really feature in either of the guidelines. So, but is considerably problematic. I've got some fun pictures to show you, of which there are some gory ones, but I will give you a bit of warning before. So approximately 2.7 million, 100,000 snake bites, 100,000 deaths, and about maybe 300, 400,000 amputations and permanent disabilities. And obviously these numbers are almost useless in that the majority of bites are remote and rural and unreported and don't come through to any sort of medical facility. So as a bare minimum, that's sort of what you're looking at. And you'll find that most people that go on expeditions love to poke and touch and grab hold of everything. And most people think of snakes on the ground. And often it's the second person in any group that, if you do disturb a snake, gets bitten, because the first one, you're sort of trudging along, making all the noise that one does when you grow up in the UK or in the Western world. And the snake is disturbed. And they think, what on earth's going on? I feel those vibrations. And then the second person comes along and out it comes if it feels threatened, and will take a grab at the ankle or the lower leg of whoever's second in the row. But once you get into the jungle, things are a little bit different. And yes, you do get snakes on the ground, but quite often you get snakes on the trees. And never underestimate the stress jungle puts on you. And I cannot sort of stress the mantra enough of shake everything that belongs to you always before you touch it and pick it up, and touch nothing that does not belong to you any times, because actually just sort of reaching out and putting your hand on the tree is occasionally enough to cost you one of your fingers. And this is my little friend. So if we were here in person and this wasn't COVID and we were able to chat, I'd ask anybody if they knew what this was, and I'd be absolutely amazed if they did. This is a snake called, in its Latin, Actras aspid bibronii, but to give it its sort of number of colloquial names, it's often called the bibron stiletto, and the stiletto is with reference to the assassin's stiletto blade. And you can't quite tell in the left picture, but he has his head burrowed underground, because this snake is a subterranean hunter, lives most of its life underground, and it sort of exploits, we think, mostly small mammal hides rather than sort of making its own. But it is incredibly and fantastically adapted for doing so. So you can see its fangs on the right-hand side. They are considerably long for a snake of its size. And the Actras aspis sort of now sits almost within its own, it sits in the Lymphophidae family. So it's previously been thought of as an elapid, it's been thought of as a verapid, it's been thought of as itself, and now it sort of sits within the others. But for a snake its size, certainly, which is about 30 to 40 centimeters, it has really quite large fangs. And the rather special thing about this snake is it doesn't need to open its mouth to bite you. So it can extend its fangs over a closed mouth. It can, and it can have maxillary rotation. So it can turn its fangs sort of to face outwards. And it has unbelievable neck flexibility. So this snake is absolutely and exclusively impossible to handle in the way that you always handle safe snakes behind the head, because it can very easily flex its head laterally and backwards and push out one fang, and it only needs one fang to deliver a very cytotoxic venom. So if you ever see a snake in anywhere in sub-Saharan Africa that's got its head burrowed like this, they very helpfully look exactly like a huge range of non-venomous snakes. So often the locals will tell you they're non-venomous. If it's got its head burrowed, you leave it well alone. Well alone. So off the sort of the top, so snake bite in general, there's loads and loads of rumors about what you do, and lots of people like to do lots of fun stuff with sucking out venom and incisions and snake stones. And I think my favorite one I came across was they found the youngest child in a village and gave him lots of traditional herbal medicine, and then had him sit on the chest of the person with the snake bite as the intended remedy, which obviously went down fantastically well. So you should aim to immobilize, if it's a limb, you should aim to immobilize the wound, and you should do so in a way that you should still just about have a peripheral pulse. So if it's a leg, you should just about be able to feel the dorsalis pedis, and if it's a hand, you should just be able to feel the radial and the ulnar pulse. And you start distally and work proximally, and you can do it. You can do it something very crude like this with a stick and just a bit of bandage. And the Actras aspis bite typically is always hands, because this is one of my girls that picked this up, and she was trying to move it to safety because she thought it was a non-venomous snake and she didn't want the locals to kill it. And he did exactly. She was very well trained in handling snakes. It did exactly what it normally does, and then bit twice with the same fang into her right ring finger. And so early discoloration is what you see first, and then I've got some rather horrible pictures. I've only picked 2 of the 15. Quite often this is potently cytotoxic, and you get localized blistering. And if you're not careful, it can progress to necrosis and then amputation, and that's exactly what happened in this unfortunate lady's situation. So I've skipped 15 days, but effectively she got a secondary bacterial infection. She was in a suitable place, treated suitably with IV antibiotics, had multiple debridements in theatre, but unfortunately she developed abscesses in the 3rd and 4th web spaces and had to have the finger amputated because of necrosis to the tendon and bone. So despite not giving quite often systemic problems, you can often get amputations, and there are stories of people sort of losing up to the elbow or higher, but typically we're talking digits, which can be a really big thing for people living in Africa or Southeast Asia when they're farmers, and they sort of rely on their ability to use and work their hands for a daily living, and rightly so if you've got a ranger or someone that needs to be able to hold a rifle like this girl. So I'm just going to tell you very, very briefly about it because it's interesting. So it's got its own unique venom pattern and it's got something called a saprophytoxin, which was first isolated from a different Actras aspis. And they're all the same bar between all of the snakes, bar 1 or 2 amino acids. It's a 21 long amino acid peptide in the bibroniae. And they are essentially analogues of endothelin, and they bind to the endothelin receptors A and B, and they can technically give you some quite significant left-sided and right-sided heart failures, depending on which one you get. So the different snakes have different length saprophytoxins, and one of them in particular gives you left ventricular dysfunction and doesn't really do anything to your airway pressures. And then the sort of shorter one, which is associated with worse outcomes from the very limited literature that we have, also gives you increased airway pressures and right ventricular failure. And on the ECG, you can quite typically see some atrioventricular block. You can get some VT, and there are some stories of progression to VF. Not in the bibroniae, there's no reports of deaths, but certainly in the others there are, and they all seem to be cardiac-related death. And it's thought that actually it's probably in those that have got underlying cardiac disease that are most at risk to these snakes. And the worst sort of case scenario for this chap is that there is no known antivenom. The boomslang antivenom has some minimal activity, but you would literally need to use the entire South African stock of boomslang venom, which 1, you wouldn't get into a person, and 2, no one's going to let you have that stuff to have sort of the effect on the typical dose that the snake delivers, which is actually very minimal, but very toxic. So snake bite in general, if it happens to one of yours, they do have to leave the expedition immediately, and they should be evacuated to somewhere that does have intensive care or surgical expertise as your first port of call. And you should do so in a way that is as quick as possible, but also doesn't have the person running along with a heart rate of 150. So basic first aid first is important. Just get everything off them. So rings, bracelets, because you don't know sort of what local edema you're going to get. And then my young girl here, actually, she ended up with some significant peripheral edema that extended up past the axilla into her face. So rings and bracelets all off first. Identify the snake if possible, because giving antivenom is really, really dangerous. And the one thing I will impart on anyone that might go disappearing off into the wild is really think about what you're doing and what you're giving. And giving antivenom outside of an intensive care setting is a really, really cowboy and risky thing to do. And anaphylaxis is a significant side effect that happens uncharacteristically often. So identification is important because antivenom comes with risks, and certainly for these snakes there's no known antivenom, and to give antivenom would be quite irresponsible if you knew what the snake was. But you must do so in a way that doesn't endanger you also getting bitten. Okay, and even if you can identify whether it's a viper or an elapid, and there's some very similar, does it have big round eyes, does it have slit eyes, does it have a triangle head, does it have a confluent head with the rest of its body, what's its skin color like? Even these things are very, very helpful to doctors that are used to living in the area and know what snakes they have around. So you evacuate out after you immobilize the limbs. Quite often the pain relief comes from immobilizing the limb, actually. So the amount of times people have said that that alone gave them significant pain relief after opioids did virtually nothing for them for their pain. Always think about tetanus. Most of these things are sort of running around on the ground. This one in particular lives underground. And you consider a requirement for antibiotics. So the WHO guidelines suggest that you should never be giving prophylactic or empiric antibiotics just because of a snake bite, but you really early signs for infection, and then you want to go for something broad-based, and something like coamoxiclav is what's traditionally recommended as a first point of call, unless you know what's growing and you've got that opportunity to get something through a lab and get a sensitivity and an identification of a bug. And you should always try and talk to a snake expert. So they know exactly what's going on in the area, and they'll give you, that's their entire life and their entire job. And early surgical referral. And the special considerations are just depending on what snake it is. So obviously some of them are going to be hemotoxic, neurotoxic, cytotoxic. And even with these ones, just knowing I should be doing an ECG. I should be making sure there's no signs of AV block. There's no T-wave inversion. I should be doing a urine dip, making sure there's no sort of hematuria in the urine and things like that. Just really simple tests that we take for granted here, and actually are incredibly difficult to get elsewhere, can still give you very, very important and early signs of what's going on.
Scott, I'm so sorry, Scott. We're really running out of time, and I've just.
So I can say goodbye. That's okay.
No, I've just been nudged. You've given such a incredible talk. I just wonder if you can wrap up so that at least everyone
in about 30 seconds. Is that okay?
Yeah, a chance to ask you some questions.
Cool.
Right.
Okay. So very, very briefly, if this is genuinely what you want to do and you want to go off into the wild and you don't want to have to sign your life up and wear a uniform, although I would highly recommend the lifestyle, then the two organizations on the right are fantastic for doing so. So the Royal Geographical Society have been doing this for decades, and they hold an expedition medicine event outside of COVID, normally in October, November time, for sort of budding people. And the Scientific Exploration Society are very well positioned to support sort of young medics that want to go off and do bits of research, and they do so in a very professional manner, and they do offer grants and things like that. So both of these are fantastic pools. And I'm going to leave you with my last quote, which, whilst you should be excited and desperate to go out, he who goes gently goes safely, and he who goes safely goes far. And just sort of forward planning is everything. There we go.
Thank you both, to Dan and to Scott. Absolutely brilliant talks, really inspiring. I've learned a load of things today. I'm not going to take up space anymore, but I do want to open the floor to questions. Zin, do you have any questions that have come through?
Not at the moment, no. So whoever's interested in asking some questions, feel free to unmute yourself, raise your hand and unmute yourself, or ask in the chat, please.
All right, we have one. Perfect.
We have one.
Please don't be shy, because this is an incredible opportunity to ask some questions to two very experienced experts. So we have a question from Nisha. It says, if you do know the snake responsible and there's an anti-venom available, how do you go about getting hold of the anti-venom for your patient? I'm assuming they are in a very limited supply. And are there any criteria for who gets the anti-venom and who do you liaise with? I think, Scott, that's directed at you.
Yeah, so I can answer this one relatively simply for some places and less so for others. So certain countries, we'll deal with Africa as a model. Certain countries are better equipped, and things like, countries like Kenya are very well equipped. So in those circumstances, you go to what we would consider like a T4 hospital.
Scott, can I just interrupt? Can we see you?
Yeah, most certainly you can. Yeah.
Yeah. So
I'm not called Stephanie, so that's.
I was just wondering, it might be nice just to be able to. There we go. Brilliant. There you are. There you are.
Hi. So places like the Aga Khan in Nairobi obviously hold stock, and it's well worth sort of getting in touch before you go anywhere, because quite often they will. You will find that the doctors there are very happy to liaise, and you can then contact back through them. For everything south of Kenya, then the African Snakebite Institute pretty much manages, and out of South Africa manages that. So you can liaise with the African Snakebite Institute before you go, and the people that run that are some of the most experienced authors in the literature for the last sort of 50 years, and they do hold some limited stock. You're never going to get it rurally. The Americans have made powdered antivenom, and that's kind of the golden bullet for the future. We haven't really found any good efficacy for it as yet, but really you go to the capital, you go to the main public hospital, and you try and work out what they've got there.
Brilliant. What I'm going to suggest is that, I know we've run over, everyone in the next minute, pile up your questions, and then I'm afraid there'll be no more. So, so here we go. Right. Fine. So the next question is from Kunal Patel. Considering the role of wild cross and poaching, are we seeing an impact on anti-venom availability? Oh, I think, have you sort of answered that? Research due to factors such as the illegal animal trade and climate change. Does that make sense to you, Scott, that question?
So very, very briefly, most of the stuff that we've been involved with is already tied into the local governments. So yes, the availability has increased, but not significantly.
Okay. I say to Dan as well, do the speakers have any suggestions for student nurses keen to be involved? Dan, have you come across anything where
Yeah.
involved?
I think there's maybe the incorrect perception that to be an expedition medic you have to be a doctor, which I don't think is true at all, really. I think a lot of it is more how you are as a person. Certainly British exploring tend to have a wide variety of paramedics, nurses. They tend to take at least someone into the same country who has prescribing powers. Powers isn't the right word, you know what I mean? So that's there's no issues around sort of taking controlled drugs or anything like that into the country. But yeah, certainly it doesn't matter if you're a doctor, nurse, paramedic. There's a huge range of opportunities out there.
Okay, wonderful. Benjamin asks, what's your thinking on being paid or volunteering to be medic on expeditions? Are they generally unpaid volunteering positions in themselves, and you go for the experience?
Yes. So yeah, it's hard. Some lucky people do maybe earn decent amounts as an expedition medic, but it tends to be, getting your foot in the door. You tend to have to do it for the experience, I guess. Then you kind of progress, get your expenses covered, and then sometimes you get paid. It's a negotiation, I suppose, like everything. But the one issue is that there's always someone who's willing to do things for free often, and I guess you have to just balance that against how much you value yourself and not undervalue yourself, but also think, well, there are things I want to do as well.
Yeah, Scott, what are your thoughts?
So it's very, very difficult because there's lots of people that are willing to give lots of money, and the more people that are willing to give money to unexperienced people always makes me scratch the back of my head and sort of think, why are you willing to pay so much for someone that has no experience? And that makes me really nervous. So for me, to get your foot in the door, there are always other routes, and you've got to think to yourself, what else can I offer? So most people that have studied medicine and gone through medicine have a good command of, sort of basic maths and communication skills. And there are going to be expeditions that go out that are going to have a core medic, but there may well be that you can sort of fulfill another role and at least start ticking off the box of, I have now been overseas and outside of my comfort zone, and I can tick that and say, look, I'm happy in the wild, I can look after myself, and that's how you sort of start. It doesn't always have to be just the medicine.
Great answer. Great answers from both, thank you. So Stevie asks, how do you approach the ethical issues concerning expedition medicine generally? That's a great question.
Yeah, I mean, I guess how long have you got? You could do a whole webinar on it. I suppose what were the main ethical issues you were hinting at? Maybe if you pop it in the chat, just because yeah, you can go. I guess that the main thing that comes to mind for me is like I mentioned in my talk, resources, inappropriate use of low resource settings, resources potentially being a drain on them, which is not necessarily appropriate. And the other thing, like this trip to Canada to help young people, we flew 60 people across the Atlantic, drove around in pickup trucks, and you think of the kind of your carbon footprint. Could we have achieved the same thing in Scotland or Snowdonia or Wales? Maybe not to the same extent, but maybe as well. And I suppose those are the two things that come to mind.
Okay, I'm going to quickly move on because someone's asked a very good question. Vanessa, when did you start doing stuff with expedition medicine? As a junior doc, are we too junior? How do you balance going to get experience and improve your skills, and also being junior and therefore maybe more inexperienced? That is always the golden question. When is the right time to start and go? I'll ask you both that, actually. So Scott, would you like to start?
Sure. So I sort of first went, I think probably exactly the same as you, so post F2, and then found myself in the middle of nowhere. And you come through, 6 jobs doing ICU and anesthetics and vascular or whatever, and you think, oh, I've got this is fine. And then you find yourself in the middle of nowhere and you realize, I really wish I wasn't here on my own. So going out too early is a problem. I think I would still do what I said before. I would go on expedition early, but not as the chief medic. And I would be looking for those expeditions that take more than one. So I spend a lot of time at the Royal Geographical Society, and over the pre-COVID period, I know of at least 3 or 4 expeditions that were being planned that were looking to employ a range of junior doctors with one sort of senior GP overlooking everything. But it was, the whole idea was to get 8-9 people out the door and get them that first badge. So it's about just finding the people that know what they've been doing for decades and sort of tagging onto that one piece at a time.
Perfect. Dan?
Yeah, I'd probably echo that. I think there's no right answer. There's no kind of correct time. I think it's the one thing that I always kind of try to remember is that even just because you've gone to the middle of a jungle or the middle of a desert, to try and remember that you still have to kind of act within your competencies and your GMC competencies and things like that. But the other thing to consider as well is with the company you're going with, is their top cover. So that's usually someone based in the UK or wherever that you can call on your sat phone or whichever communication device and run things by them. Or sometimes that's outstaffed to other companies that will provide that. But there's usually some sort of overriding sort of support. And if there isn't that, I wouldn't touch it with a barge pole.
I'm going to be very ambitious. There are, I think, 5 more questions, and we're going to have 30 seconds on each one, just so that everyone, and then I'm afraid no more questions after the last one, which was at 11 minutes past. That's it, curfew. Right, now I'll go back. So there is a 3rd-year student, Sarah Hilton, who has asked, I think almost a similar question, but she's asked, at what stage would you recommend going on training courses? I'm going to just say this now. I'd say start now. If you're already involved with the Wilderness Medicine Society, fantastic. Just start now. Just always check the eligibility criteria of each training course. If it says you can go, go. If it says you've got to be, post-graduation, wait until you're post-graduation. Anything that you would recommend? I personally would definitely recommend the DTMH, the Diploma in Tropical Medicine and Health and Hygiene. MSF are doing one. It's online. It's the Global Humanitarian Health Medicine Diploma. It's online. I'm on it at the moment. It takes a bit longer, but it's also cheaper than the enormous amounts of money Liverpool and London. I couldn't afford it, but I can afford the MSF one. I'll just move on, but yes, the answer is yes. Start now if you can. This is one for you, Dan. Golden question. I actually even wrote it down myself when you were speaking. How do you manage your GP life with expedition? Are you using annual leave? That's from FC.
Yeah, so I, as in my talk, I have a very strange GP life in that at the moment I'm not actually doing much general practice, even with COVID going on. So yeah, I work as a locum before COVID, so annual leave is kind of when I want it to be. That's why I still am not a partner or a salaried doctor, because I think it would be really difficult unless you had a really understanding partner within your surgery to just be like, oh, I've got this trip, I'm just going to leave you to.
Absolutely. I've also wondered, if you could create a unit or something that is totally comprised of similar-minded people. That's the only other way to do it. So everyone takes their
locum agency for expedition doctors or something.
So Fine. Scott, the next one's for you. For someone already involved in military medicine, would you recommend a diploma in expedition medicine or similar?
I have some very strong opinions about the expedition medicine diplomas, which probably shouldn't share. I haven't done them. Is the first port of call, and I think just be very, very careful about a diploma that is going to tell you with a bit of paper how to go out and do something that then people are going to assume you have that experience. So I'm going to echo what you said before. The DTM&H is an incredibly useful diploma. In fact, the Worshipful Society of Apothecaries DMCC diploma is incredibly well priced and also quite helpful with a lot of information, and sort of forms the other half of the DTM&H. There are lots of little courses out there that aren't a diploma in remote medicine or a diploma in expedition medicine. I think is probably a better place to start.
Okay, perfect, thank you. Can you list some entities that recruit expedition doctors with little or no experience, and some courses that would? I think we might have answered some of that, so sorry Gonzalo, I think we've done that. They go on to ask what's some channels that, I think we've answered that one. What would be the top 3 advice tips for pursuing wilderness medicine? Top three from each.
Top 3. I think we've covered quite a lot of them. I mean, it's something we keep coming back to, but it's the non-medical side of things, like Scott was being saying. So, for example, at the moment, I'm focusing on trying to sort my mountain leader out, because as well as being a medic, it's really useful to actually know where you're going, because if you get lost and when you're trying to find the casualty, then you're useless. And so I think it's thinking laterally about all those other skills. That's one. Scott, you can go for number 2 if you want.
So it's always easy when you live in London, because everything sort of is just so close, and it's always much harder when you're away, but perhaps COVID will change that with everything being online. So it's just network. You don't have to have gone somewhere. The wonderful thing about expedition, people that are interested in expedition, is that the egos tend to be relatively small, and everyone's just interested to hear about what you want to do and what they've done, and most people are very inclusive. So just reach out, network, and I think things like the Wilderness Society and RGS and SES are good places to start.
And I just think it's just get out there, just get outside. You don't have to go, you don't need a plane ticket to have an adventure. You could do it here in the UK, and there are plenty of opportunities to be able to do that. So just, don't wait for that opportunity, just go. You've got some leave, get your backpack and just go. Gonzalo, sorry if I've pronounced your name correctly, from Portugal, and has a lot of questions, but I will put one in. They're asking about entities for first steps, and from an international perspective, I'm not sure of any. Does anyone have anything? Some channel, what are your recommendations for first steps, and what entities do you recommend, particularly from an international perspective, because they are in Portugal and they don't have the opportunities that we have here? I don't know of any global.
I mean, I'd probably say fly to the UK and go on one of the courses here. So I was working on a socially distanced wilderness medicine course last month, and one of the participants had flown all the way from Mumbai to do the course. So I guess that's one option. There's also, this is a bit of a plug to my disclosures that I'm writing for this company, but there's an online expedition medicine course at the University of South Wales. So there are things out there. And there's also quite a lot of free content around, and podcasts and things like that.
The DTM&H is international, is it not? I think they do 50 and 50 from MSF.
That's very true. That's very true. The DTM&H, the Global Health, Humanitarian Health Medicine diploma that I'm doing with MSF has a significant amount of international students. Actually, that's a very, very good point. I would look up that. The MSF GHHM course exceptionally good course. I'd look that up, and that's online as well. Okay, I am so sorry. We've breached. I'm so sorry. We've gone way beyond the timeline.
No, thank you very much for staying. Definitely.
Fascinating talk.
Yes.
And I'll hand back to Zin. Thanks for having us.
Yep. Yes, thank you very much, Dr. Saleyha, for chairing, and Dr. Daniel and Captain Scott for giving us this very inspirational presentations. So I hope everybody's enjoyed this evening, and if anybody's interested in asking more questions, feel free to pop us in the chat, and we might be able to answer them and put them onto the website. I'm just going to quickly share screen, and please, if you have 30 seconds to spare, please give us some feedback. And we have similar talks in the works, so if people are interested, we're happy to continue events. So do give us feedback, and yeah, and I've also got one more thing to plug. Just let me quickly share a screen. So I've got one quick thing to plug. So please scan this QR code. I'll come back to it to give us some feedback. It's a Google document. Follow us, and so next Wednesday we have another talk, and this is going to be on COVID and communication during the COVID period. So there'll be things like fake news and stuff like that. So look forward to it. Right. So this is our QR code. So please feel free to give us any feedback. And yeah, I think that's pretty much it. Thank you very much for coming. And thank you very much for the speakers in the chair again.
Yeah, thank you, Jim. It was really good. Thanks for having me.
It was really enjoyable.
Thank you. Good night.
Good night, guys.
Thank you very much.
Have a good evening. Bye-bye.
Done.
So there are some SFGH committee members in the chat. If you wouldn't, in this meeting, if you wouldn't mind staying, so Munya, Zin, and Stevie, and everyone else, feel free to leave. Thank you very much for coming this evening.
Thank you very much, Jen.
Yep, thank you. Have a good evening.
Thank you.
There we go.